everyone. Assalamu alaikum. On behalf of YK Orthopedics and Pakistan Orthopedic Association, I'm highly honored to take this opportunity to welcome you all today for this webinar. Before we start, for any meeting, we start with the name of Almighty Allah. So we'll have a few verses of Quran reciting in front of you now.
وإن تبدوا ما في أنفسكم أو تخفوه يحاسبكم به الله فيغفر لمن يشاء ويعذب من يشاء والله على كل شيء قدير.
صدق الله العظيم. Thank you everyone for listening. Our center, YK Orthopedic, was established in the year 2020 with an objective to promote education of both patients and surgeons. And our aim for today's webinar is to discuss the controversy between ACL reconstruction and repair. We have among us several distinguished personalities, including President, Pakistan Orthopedic Association, Professor Ghulam Mustafa KK. He was the ex-head of Department of Civil Hospital, Karachi. A very dear friend, and he helped me a lot in organizing this webinar. But I can't say more about my dear friend, Professor Amir Jalil, Vice President since Pakistan Orthopedic Association. He's the head of department at Abbasi Shaheed Hospital, which is the tertiary care hospital in Karachi. And when I discussed this idea of this webinar, he was very open for it, and he supported me and provided me all the support at the background that has made this webinar possible. And I can't say enough thanks to him, and also to Mr. Saad, who's the Secretary of Pakistan Orthopedic Association, for arranging this webinar. So we all know about ACL reconstruction, and we know that currently it is a well-tried and well-tested procedure and considered as the gold standard for the management of ACL tears. But everyone in the know also knows that not every patient needs a reconstruction, and there are a number of people who do well with physiotherapy if they commit to an intensive physio rehab program. But having said that, we have to consider the good work done by Pazinski, who is the leading ACL surgeon, and he documented after reviewing his 500 ACL constructions that if we delay surgery by more than 5 months, this doubles the risk of the patient developing a meniscal tear, or if ACL surgery is delayed for more than 12 months, then the risk of patients developing a meniscal tear increases by a factor of 6, which is almost 600%. So the big question around the corner nowadays is, should the patient have an ACL repair or an ACL reconstruction? So as I said earlier, the ACL reconstruction is considered as the gold standard for ACL tear, and we have different graft options for that. To present the first talk regarding graft options, I have Dr. Naif Aslam. He graduated from the University of Leeds School of Medicine. He did his training from Yorkshire Deanery. He got his CCT in 2019. He did many fellowships, including trauma fellowship and a hip fellowship, and currently he's a sports fellow with the ROH with Professor Snow. I would request Dr. Naif to kickstart the session with his first presentation.
Can everyone see my screen?
Yes.
Yes, so Assalamu alaikum, and thanks very much for the YK Ortho team to invite me at this webinar. It's a pleasure being and an honor to be on this faculty delivering this webinar. So I am a arthroscopy fellow at the ROH, and I work at we're the Orthopedic Network. We're a group of individuals in the UK forming a deep, intricate network to further the education of orthopedic surgeons. And my presentation today is on graft options for the primary ACL reconstruction. So our learning objectives today are to identify the important factors affecting the choice of graft, and also understand the pros and cons of the different types of grafts that we have. And hopefully this should help inform an algorithm for the surgeon starting off to do ACL reconstruction. So the factors affecting choice of graft include many of the following. Age is quite important. We know that there's an increased re-tear rate with younger age, and therefore a good consideration to a good graft is a good thing to do in managing these patients. Open or closed physes with growth remaining. We need to ensure that when we're crossing the physes that there's no hardware or bone present at the physes which can disturb growth. Laxity is also very important and can be taken into consideration when choosing graft type. And of course, activity level, determining what type of activity the individual is into, whether he's a forward running activity or a cutting type sport and pivoting type sport. And the size of the patient is very important, because some of these grafts that we're taking, especially with bone plugs, are very much dependent on the quality and size of bone that we're taking them from. And of course, previous surgery and injury is very relevant. If someone's already had their graft taken, or they've got scarring around the medial side, which makes a hamstring graft difficult to obtain. So therefore, it's important to take all of this into consideration. So what is the ideal graft? So the ideal graft is one that gives us minimal donor site morbidity and minimal complication rates. We want the graft to remain in place and not re-tear. We want it to incorporate very, very much in a quick manner with a quick recovery so that our patients can get back to what they're doing. And of course, we wanted to restore the anatomy and biomechanics of that patient so that when they do return to activity, they return back to activity as they did before. We want a reliable surgical technique by which we are able to obtain this graft reliably and carry out our operation. And of course, the size of graft obtained is quite important, especially when it comes to hamstrings. And we want this ideal graft to be applied to a large population cohort, whether they're lax or whether they're not lax. It doesn't matter what their age is. It doesn't matter what activity they do. It's got to be something that can be applied to a large population cohort. So other than just graft choice, there are several other factors which we're not going to discuss today in the presentation. Things like the dark side of the knee, lateral tenodesis and ALL reconstruction in addition to ACL reconstruction, type of the graft preparation, how we fix the graft, the location of our tunnels, whether we've taken tibial slope into account and addressed other factors such as laxity, and what we're doing a transportal or transtibial tunnel technique for fixing our grafts. So with regards to grafts, these are the main types we have. An autograft, which is taken from the same individual, an allograft, which is a donated tendon from a deceased, and these can be either with or without bone plugs. And of course, then we have synthetic grafts. So with regards to autografts, our gold standard in large number of studies has been the bone tendon bone graft. And then we've got the very popular hamstrings graft, and then the resurgence of the quadriceps tendon, and of course the peroneus longus tendon, which is largely used in Asia. So with autografts and allografts, we can see that initially you have an early graft healing period, and then the graft weakens with time and picks up again. And this is one of the main reasons why we don't advise our patients to return back to sporting activity, due to the weakening of the graft initially, and as it picks up its strength to achieve that of the original ACL. So the first graft we're going to discuss is a bone tendon bone autograft. This is taken from the individual through a central incision. A bone plug is harvested from the patella and tibia on each side, and the central patella tendon is then harvested and fixed in place. Now, the pros of this type of graft is studies have largely shown that it's got a lower re-tear rate compared to other autografts. The bone plugs mean that you get faster incorporation in the femur and tibia compared to just all soft tissue autografts. There's also a good outcome with regard to return to sport, and many surgeons advocate using BTBs for those who participate in athletic activity. And of course, there's a reliable size of graft obtained. And studies have also shown an improved postoperative stability. But then, of course, there are cons to the graft as well. We found that there's a rare incidence of patella fracture in approximately less than 2 to 3%, but there is a very high rate of anterior knee pain associated with this and a sensory loss. And this can be attributed to division of the infrapatellar branch of the saphenous nerve. And then you have the issue of graft tunnel mismatch, where once you harvest the bone from the patella and the tibia, the whole construct is a lot longer than the tunnel of the femur, tibia, and the interarticular distance of the ACL. And therefore, the bone plug that you harvested is sticking out of the tibia. And then another con is in higher rates of. And then we've got the Springs autograft. This is largely what I've used in my fellowships. It has a very reliable technique, and when it's quadrupled, it actually has a greater ultimate tensile load and stiffness compared to your native ACL and your BTB. And large amount of studies have shown that if you harvest a graft more than 8 millimeters, your outcomes are quite good and your re-tears are low. And this can be obtained, as you can see on the left side, by folding your graft, not just using a 4-strand tendon, but potentially folding it, making a 5 or a 6-strand graft, just to ensure that you keep that 8 millimeters in check. And of course, it avoids the complications of BTB, which are anterior knee pain, which can affect a kneeling type population, such that we have in Pakistan, where people are praying and kneeling for their work and activities, and it avoids a complication such as that. But there are, of course, cons to every graft. And the cons of the hamstrings autograft is instead of bony incorporation in the femur and tibia, you have fibrovascular scar formation. There is an increased re-tear rate compared to BTB, especially in those individuals who are hyperlax. And this was shown by the Moon study group in the States. And we found that patients with hamstring autograft reconstructions had a higher laxity with increased side-to-side differences and increased laxity in the KT1000 measurements, though there were no differences in patient-reported outcomes despite that. There's also the con of a variable anatomy, and we do, kind of have a surgical technique in order to harvest this, but variable anatomy can sometimes make harvesting this graft difficult, but surgical expertise is key over here. And there's variable graft diameter, whereas some individuals have tried to identify through preoperative imaging what the size of graft may be obtained. This has not been regular practice across ACL surgeons, and therefore this is something that we have to counter by folding the graft or making it a 4, 5, or 6 strand. And then there's the issue of tunnel widening, where you get a windscreen wiper effect. So your fixation in the tunnels is very important. And donor side pain can be present in a very few number of patients and can lead to some flexion loss. So recently, there's been a meta-analysis of randomized controlled trials comparing BTB and hamstrings. And they actually only included randomized controlled trials with a minimum of 5-year follow-up. And what they found was that BTB led to more kneeling pain, more anterior knee pain, and extension loss. And in fact, there was a higher rate of failure in the hamstring graft, whereas there was no differences in PROM scores, in stability, return to activity, and overall arthritis. And we look at the forest plot from their study, we can see that the re-tear rate favors BTB and 5.5% compared to 9% hamstrings, which is quite significant. So how do we decrease the failure rate of autografts? And some people have advocated addressing the dark side of the knee, which is the anterolateral ligament complex. And this has been theorized because Andrew Amos's work showed that ACL injuries usually are in combination with anterolateral ligament complex injuries. So there's been two main studies, one from the Santee group and one from the Stability group in Canada. And they essentially found that when you do an anterolateral ligament reconstruction, you can decrease the rate of tears in your autografts by 2 to 3 times. And with a stability graft, the stability study, they found that we can more than half our re-tear rate with a lateral extraarticular tenodesis. And then, of course, we've got our other autograft, which is the central quadriceps tendon autograft. This is obtained with a either vertical or horizontal incision, centimeter breadth above the patella superior border. And the pros of this is it can combine the best of hamstrings and patella tendon. It can avoid the complications of both of them. It has comparable outcome scores to both of these other autografts, and has a greater intra-articular volume than the BTB. So if you look at the MRI image on the bottom left, if you just look at the thickness of the patella tendon compared to the quads tendon, you could see that there's a big difference and almost double the size, which a lot of people found very useful. And this size is also found histologically to have 20% more collagen than the BTB as well. But one thing to take into account for quadriceps tendons is as it comes down and inserts on the patella, it is one tendon, but as it goes more proximally, the rectus femoris and the vastus intermedius come straight down the patella and attach there, but your vastus medialis and lateralis come in an oblique fashion, similar to what the abdominal fascia does. And therefore, that may be proposed in some of its cons and with regards to re-tear rates. So people advocate special equipment to Harvard quadriceps autograft, but recently Laprade published their paper on just using simple instrumentation for this. There's also a worry about the length of the quadriceps graft, but you can often combine this with a bone plug from the patella to achieve the right length. And there are partial thickness and full thickness options, but with full thickness options, there is the risk of breach of capsule and extravasation of your arthroscopic fluid, which may make your surgery difficult. And currently, we're still looking at long-term data because the Danish registry showed higher failure rate with quads, especially if you're doing less than 100 a year, which I thought was quite significant. And then we have the autograft peroneus longus tendon. I have to be honest, it's a technique that I've never done before, I've never seen before, but on studying about this from Freddie Fu's group, they compared this to hamstrings, and the large amount of studies that they looked at were retrospective trials. But they found some really interesting results. So they found better outcomes with the peroneus longus tendon compared to the hamstrings tendon. They found that the re-tear rates were comparable, and it really avoids mobility of the knee. And that's why your outcomes are better with peroneus longus tendon. And it's very useful in the multi-ligament situation to have something in your armamentarium that you can use. The cons are that it's a relatively new technique, although I do understand that my colleagues from Asia are a lot more experienced than what we are over here in the UK. There is still developing literature with regards to this, and we look forward to this space to see how that develops. Donor site mobility from Freddie Fu's paper was found to be 4.35% with discomfort and a numbness around the harvest site. And they also found slightly decreased AFAS scores when obtaining grafts. And of course, a surgical expertise is necessary in order to do this, as there's different techniques. Either you take the whole of the peroneus longus tendon or the anterior and posterior slip, and you suture the rest onto the peroneus brevis. And then, of course, we've got allografts that can be used. So it seems like there's a lot of pros when it comes to allografts because you're not actually inciting any further surgical insult to the patient. Your surgical time is less and your tourniquet time favorable. And it's especially useful in the multi-ligament and revision cases. I've done several of these with my supervisors over here at the ROH, and really allografts have been extremely useful. They're known length and diameter, so you know where you are before you attempt to do the operation. And they can come with and without bone plugs, which can be quite favorable for fixation. But of course, the cons are that they are very expensive and availability has been an issue. And certainly there's slower incorporation of these grafts, in excess of 18 weeks sometimes, to fix into patients. And the Moon study group found a very high failure rate. And this is especially the case if these grafts are irradiated in a significant fashion. So this is the graph from the Moon study group showing that the allograft has a significantly high failure rate in those under the age of 35, as can be seen the red line with regards to retear rates. And this is much higher than the Autograft's BTB and hamstrings that you can see on this. So it's advised not to use allografts for younger patients for primary ACL reconstruction. And this is a table from the Saudi journal, which summarizes the different tensile strength. And interestingly, you can see a quadrupled hamstring is 4,090 newtons in its ultimate tensile load and forms the strongest one. And the intact ACL is 2,160, and most grafts do go quite high above that. And then, of course, we've got synthetic grafts for ACL. These came in various forms, but unfortunately, these have largely been superseded by autografts because of high rate of failures with retears. There's also been incidences of synovitis and effusion in patients, which led to arthritis, and of course, tunnel osteolysis, which makes revision a horrendous operation to do. So the question is, what graft should I use then? How do I determine what graft is best for a patient? So the Moon study group has came out with their risk calculator, but this is only applicable to those under the age of 22. They looked at thousands of ACL reconstruction with long-term follow-up and found that there were certain preoperative factors that can be used in a calculator to help determine the risk from BTB and hamstring retear rates. And this has certainly been validated recently with a study from the stability trial. And it can inform the surgeon and the patient about retear rates between these two major autografts and help choose which one would be best. So if you go back to the slide about our factors affecting choice of graft, all of these have to be taken into account. But what's more important is that we take your training into account with regards to what you're most comfortable doing. The volume of surgeries, as Danish registry has shown, that if you're doing a low volume of quadriceps, your retear rate is high. Your surgical expertise is very important, and I think being a soft tissue knee surgeon, having 2 to 3 graft options is a very good idea, just in case you have a multi-leg case, or if you're trying to harvest a graft and unfortunately the technique fails because of patient anatomy. And what's most important in all of this is patient choice. Patient choice, giving them the options, telling them the risks and benefits, and getting them involved in decision making is paramount in helping choose the right graft. So on a final note, there is no ideal graft, and every graft has its pros and cons. All of these have to be taken into account, and very importantly, your surgical expertise and what you're comfortable in doing. So I'd like to thank you very much. And I have a plugin for the Orthopedic Network over here on our website. We would love to be involved with any future educational activities. Please feel free to be in contact with us. Thank you.
Thank you very much. That was an excellent presentation, nice. Let me just go back to the next one. The important take home, I think, here is that there is no ideal graft, and we have a high tear rate with the primary ACL in the long term when we look at the long-term outcomes. So how to avoid it? As you mentioned, that maybe ACL with ALL reconstruction could be an answer to it. To learn more about it, we have Dr. Acl from Greece. He's a good friend, hail from Castoria. He's a military orthopedic surgeon, and he also works at Biomechanics Advanced Shoulder Clinic in Athens. He did his shoulder and knee fellowship in France, and he did his PhD studies in basic sciences of shoulder rotator cuff pathology. He has a number of publications in PubMed. He contributed to many chapters in textbooks. He's an editor of an orthopedic textbook as well, and he has over 100 presentations. He is an active member of ASCA and European Shoulder and Elbow Society and Hellenic Arthroscopic Society. So I welcome Dr. Acl, and we listen to his talk on ACL with ALL reconstruction, tips and tricks. Thank you.
So thank you for the invitation. I'm really honored to be here and to participate to this webinar. Do you want to continue? Yes, sir. Can you see my screen?
Yeah, that's brilliant.
So really honored to participate here, and I'm going to talk about the combined ACL and ALL reconstruction. And we know that in the early 80s in France, everybody used the BTB allograft. And then in the 90s, it came the hamstrings. And initially in the United States and after in France, they start to use the hamstrings more and more. It was more easy to do it and with less donor site morbidity. However, and also in the year of the 2000, Freddy Fu came with a double, from the single bundle, he proposed a double bundle technique. Also, our materials were very, the development of the materials was great during these decades. And we passed from the screws and the pins to the buttons and the stable buttons and right now to the adjustable buttons. However, when we see in a systematic review, the anterior, the failure from the ACL is about 12%, and we have 3.2% and the study says that 3.2% is the really failure, and the clinical failure can reach about 30%. And also, if we see, does the ACL reconstructions alter the natural history of our knee? And if we compare between knees that are not operated and operated, we can see that we have less need for further surgery in the patients that they are already operated, less need for further meniscal surgery in the patients that are operated, and also the pivot shift test is also better in the patients that are operated. However, if we can see in this study, about 1/3 of the patients that they are operated with an ACL reconstruction have a residual pivot shift positive. So in 2013, it comes Stephen Kleis from Belgium, and he says that we have another ligament outside of our knee, and he calls this the anterolateral ligament. And he gave us some points of the anatomy. It's about 83 millimeters in front of the lateral collateral ligament. It's about 20 millimeters behind the ZD tubercle, and also it's about 6 millimeters from the articular side of the tibia. And also he says that the second fracture is nothing more than the attachment of the anterolateral ligament on the tibia. Since then, it started the Star Wars, and it started the Star Wars between the French guide and between the American and English guide. And do we really have an anterolateral ligament? So when I have started to search this to perform a meta-analysis in 2018, I had 600 publications in the PubMed, 686. And right now we have over 1,000 publications regarding the anterolateral ligament of the knee in the PubMed. Does this exist? And the anatomic studies, some guy says yes, 100%, and sometimes some guy says no, 0%, they couldn't find the anterolateral ligament. And we have anatomic evidence that there is an anterolateral ligament. And the radiographic evidence is not obvious many times. We have studies that he says that 100% I can find it from the femoral part, from the tibial part, from the meniscal part, but sometimes it's not evident. And I have to admit that this is not reproducible. If I give the same MRI to 10 surgeons, I don't think that is very reproducible to find it in an MRI. So this is the femoral part of the ALL, the meniscal part of the ALL, and the tibial side. And you have to look very, very carefully, and depends from the way that the MRI has been done. So this is an MRI that we can see that probably the ALL is torn. And some guys started like from France, Henri Cotet, and to find it arthroscopically. And they say that 100% this was present. From my point of view, I've also seen some cadavers, and I have seen it and about 100% that there is a structure right here that it seems that is an ALL. And the importance is also to prevent excessive internal rotation, however, not to over-constrain the knee. And regarding the biomechanics, where is attached to the femur? Claes and Helito, it says in front of the tubercle of the femur. Also, Dodd says behind the tubercle of the femur. And some guys says onto the tubercle of the femur. However, what we know today is that is an anatomic structure that is not isometric. And this is from a very, very good study from Imbert that it says is really, really tension between 0 and 20 degrees flexion of the knee. However, do we really need ACL and ALL, and when and how? We performed a study in France, in Grenoble, to compare the two techniques when we're using screws in the femur and the tibia and an adjustable button on the femur and also on the tibia in order to see what is the advantages of an adjustable button. However, when we performed this study, we have seen that when 1,136 ACL reconstruction, we compared two groups with these materials, 121 and 151, that they were comparable preoperatively and comparably also to the laxity and the pivot shift. What we have found is that we have residual laxity about 2 millimeters in both groups. And we found that the preoperative laxity was also relevant to the preoperative pivot shift test. And also the post-operative laxity was also statistically significant against with the preoperative pivot shift test. The patients that have greater pivot shift test preoperatively had also greater residual laxity 2 years post-operatively. And we can see that the patients that they have preoperative laxity, preoperative pivot shift test 2 or 3, they have predicted probability to have post-operative laxity above 3 millimeters, that this is statistically significant and this is clinically relevant. It's not very good to have post-operative laxity 3 millimeters. And also, we found that the age is another factor that the patients that are very, very young has also increased post-operative laxity above 3 millimeters 2 years post-operatively. So from this study, we found that the patients with 6 millimeters preoperative laxity with a pivot shift test above 2 and also age between 20 years old are increased post-operative laxity after a simple and single ACL reconstruction, either with a screw or either with a button. So we came out with this technique to use a combined anterolateral stabilization of the knee using also hamstring tendons and adjustable loop fixation device. And we started to use in revision cases with a techno-activity scale above 5, with the BMI above 25 in a recurvatum knee, and also in delay with patients with a delay above 12 months. And this is our video that it was published in the arthroscopy techniques. And I'm going to explain you the tips and tricks. So we have a 20-year-old rugby player that he has 10 millimeters laxity, and we see the video and we see also the pivot shift test. It's a 3, it's an explosive. So we mark the epicondyle of the knee and the ZD. This is very, very important. We harvest the hamstrings and we see the joint. This is a revision case, and also the patient has a small meniscal tear. We have no remnants in this case. And we make our tunnels from the femur, and we do it from outside in. We place the guide, a special guide, and we mark the epicondyle, the femur epicondyle. And this is the insertion point, and we see the guide that is at the stump of the ACL inside the joint. And we prepare a 6 millimeter femoral tunnel. We make the same thing for the tibia. Then we found the ZRD, and we go a little bit posteriorly. And using the knee, the guide for the tibia, we make a tunnel that starts from the medial side of the knee and goes behind the ZRD tubercle. We also measure the length of the anterolateral ligament and all the length of our graft inside and outside the joint. So when we have measured the length of our graft, so we're preparing the graft, a 4-star graft for the ACL that's going inside the joint, according to the length that we have already measured. It's a typical 4-strand graft. It's an XL adjustable button that is attached to the tibial side and only a suture at the femoral side. And we use the remaining graft from the gracilis to perform the ALL, or the lateral extraarticular tenodesis. You can say it as you wish, but it's one band and not two bundles as Bernard-Sonnery Ricotte performs. And at the end of the graft for the anterolateral ligament stabilization, we have an adjustable button, a small normal adjustable button. So you can see finally the graft, the intra-articular part, 2 centimeters in the tibia, and the extra-articular part. So finally, we complete, according to the graft diameter, we complete the tunnel of the femur and also the tunnel of the tibia. This is the femoral tunnel, and then we go to the tibia. We clean very carefully and we verify the integrity of the tunnels. And finally, we make the final tunnel to the tibia from the anterolateral stabilization, about 6 millimeters of diameter. A lot of suture you can see. We have one suture to pass the graft from the tibia to the femur. You can see here, we start to pass the graft. It passes the gracilis outside. We see the length, we see it inside the joint. This is the blue suture that confirms that we have 2 centimeters in the tibia. We fix the graft in the femur with a screw, and also the graft on the tibia with the adjustable button. And we verify it. Then we pass underneath the iliotibial band, the extra-articular part. We elongate a little bit the adjustable loop to pass at the other side. We pass it from the other side in the tibia, and then we fix it in about, right now I'm doing it 0 degrees of flexion in extension. Before 5 years, we have done it in 20 degrees. I think in 0 degrees it's better. And we have the final evaluation, anterior-posterior stability, and no pivot. This is the final image.
Thank you very much.
It continues a little bit.
Okay.
So we have further indication in meniscal injuries. It seems that the anterolateral ligament, it protects our repair of our meniscus, and especially in bucket handles and also in ramp lesions also. Also, when we have second fractures, I'm always performing this technique. When I have lateral femoral node sign, and I can see it either in the MRI or in the or arthroscopically, I am performing this technique. Right now, when I'm performing an ACL repair, I'm augmenting this extra-articularly because I think that it protects the graft from rotational forces and permits to maturate our primary repair. And also, we compared all the possible techniques in our study that was published in ESCA. button screw, screw, ACL plus ALL, only with a patellar tendon graft or patellar tendon graft augmented extraarticularly with a fascia lata. And we have seen 2 years postoperatively that our technique gave us the best results in postoperative laxity and also gave us the best results regarding the residual pivot shift test. Also, the graft failures was 0. I don't know if this is continuous during the time, but 2 years postoperative, we didn't have any failures. So if we go back to the Lyon school, we can see that in 1967, Lemaire said that we have to do something extra-articularly, and he proposed this technique that many guys are continuously performing today. And also we have seen the publications of Colombe in 2011. He proposed a little bit this technique that we have to combine the ACL with something extra-articularly. So the take-home message is the lateral structures that very important exist. However, are they its own during ACL tear? Are they elongated because the ACL doesn't function very, very well over time? However, it seems that something extra-articular to put it, it protects our graft and probably protects our meniscal repair. And we don't know exactly the isometric points of fixation today. ALL or lateral extra-articular tenodesis, anatomic or not anatomic, I cannot answer this question. However, I know that we have to find a balance in the knee in order to pass this mountain that it said ACL failure. Thank you a lot for your attention.
Thank you very much, Dr. Acl. That was excellent, really. Very interesting indeed. And we are doing all this because as a sports surgeon, there is, we know, a fear of long-term failure with ACL reconstruction, and we're trying to augment our reconstruction in order to prevent the re-tear or decrease or lower down the rate of re-tear in ACL reconstruction. And many researchers are working on it with new ideas in order to reduce or improve our outcome for ACL reconstruction. One such brilliant mind is Prof. Damir Hoyts from Croatia. He's the chairman and Department of Orthopedics at St. Catherine's Hospital. Graduated from University of Zagreb, Croatia. He's considered as an expert in knee preserving and replacement surgery. He's the president of Croatian Biomechanical Society. He's been the principal investigator in several clinical trials. He's the author and co-author of many scientific papers and few chapters of orthopedic books. And I would love to hear his talk on biological ACL reconstruction. And so, Prof. Damir, dice is yours now.
Thank you very much for the introduction. I'm really honored to participate at this webinar. So let me just start sharing the screen. Okay. I hope you see my presentation right now.
Yes, you're okay.
Thank you. So the focus of my presentation will be a kind of reconstruction of ACL, of anterior cruciate ligament. And here are my disclosures. And to summarize and outline the presentation, I will talk much more about biology of ACL reconstruction and the rationale behind our approach to this subject, and I will show you one of our studies on capacity of muscle-derived stem cells in order to promote graft healing and its use in primary ACL reconstruction. So we have heard today that the hamstring grafts are probably most abundant grafts, at least according to some European registry as the Danish ACL reconstruction registry, and they tell us that basically in the last 10 years, 85% of all grafts for primary ACL reconstruction in Europe has been done with hamstring grafts. And why is it so? We have heard so far that it's due to simplicity of the harvesting and of course due to low harvesting site comorbidity. And we have seen biomechanical studies that show that these grafts are really that they have high resistance to load, and they show very high strength characteristics. We have seen also patient-reported outcome measures that show favorable clinical outcomes of these grafts. So does biology of all these grafts that we use matter? There are really tons of papers that speak about favoring all concepts of ACL reconstruction that put biology into account. So we have seen a lot of papers that report about the difference when we compare allografts to autografts. And that the allografts have a lower survival rate comparing to autografts, and it's very well described due to the biological properties of these grafts and due to acellular grafts. And these grafts that we use as allografts tend to be really just collagen bundles, and they tend not to be a real tissue graft. So we have also seen a lot of papers that advocate the use of so-called samba technique, where we preserve the remnants of the anterior cruciate ligament at the tibial side, and they promote, the remnants promote ligamentization of the graft. They promote proprioception after ACL reconstruction. And we know also from many studies, one of which is presented here, that the less foreign material we leave and we put into the bony sockets or bony tunnels, the better tendon to bone or graft to bone integration within the tunnel or the socket is. So these are three major perspectives that really tell us that biology of these grafts really matters, and we all want to avoid this sort of MRI imaging or this sort of status after ACL reconstruction, where we see a lot of liquid and where we see that the graft has been torn within the bony tunnel, and that the graft even within the joint has been torn, and it's due to some biological issues. So how does biology look like? We have seen already today this this chart and this curve. We know that 1 to 3 weeks after reconstruction, a lot of inflammatory processes within the knee that has been operated occur, and then 3 to 5 weeks after reconstruction, if you take a look at the y-axis, that the strength of the graft is diminishing, and then it's the weakest at the time point approximately 6 weeks after the surgery. So we have to take that into account, because our graft becomes hypocellular, and then we need to take into account as well what sort of graft and what sort of graft tissue are we putting there in the knee at the very beginning, at the time point 0 when we do our surgery, because we can expect additionally cell apoptosis, and then it leads to lowest mechanical strength of the graft at this time point 6 weeks after surgery. So it's something that's very well known even from the 1980s. So already 40 years ago, this biological kind of knowledge has been there. So what are the critical points from perspective of biology of these grafts? Tendon to bone ingrowth. We are putting, or we are placing tendon or ligaments within our tunnel, so we expect something to occur at the interface between these two tissues. We even expect the tendons to undergo the process of ligamentization, which means that the tendons become ligament-like structures. There are many differences from histological perspective. And then the critical point is also bone loss within the tunnel, where we have inflow of synovial liquid within the tunnel. So it all influences mechanical properties of the graft, and we have also mechanical issues with attachment, with the surface attachment. So how does it look? So our ligaments act like springs, and they allow a little of strain in the axial length of the ligament. So it looks like springs. So we are putting our ligaments into either socket or tunnel, and we do that. And the native biology of the ligament is that we have really perpendicular fibers that attach to the surface of the bone. So we are changing the environment. So our ligament biomechanics is really complex thing. And even if we start with a graft that has much lower biological capacity, then we tend to compromise our whole surgery. We are also addressing rehabilitation, because we have seen that there are differences at certain time points after surgery, where the biology plays a really major role, and we are applying so-called bioreactor rehabilitation, but that's another topic. And just to let you know, there is a really high demand to really adjust the rehabilitation process according to all the biological knowledge and biomechanical knowledge that we know, because biology influences our end result. And then there is this issue of Acl revision surgery, where we have huge bony defects, and they present significant problem. The size of the defect decides really whether we do or whether we undergo 1 or 2 stage procedure for the revision ACL surgery, and it influences the type of revision graft. We have heard a lot of revision about grafts today, and I will present you what we know from our studies. So our major question from our group was whether we can improve innate capacity of the hamstring grafts. Why hamstring grafts? Because I have explained that we use... Sorry, can you hear me?
Yeah, we can. Go on.
Okay. So we have published a study on this topic in 2017, where we showed that there is some sort of capacity of our hamstring grafts, and the primary point was the way that we have been taught, and at least I have been taught to prepare our hamstring grafts, and that's the standard operating procedure, where you meticulously separate all the muscle tissue from the remaining tendons. So you kind of discard all the muscle tissue, and then you put a graft that it looks very shiny, very nice, very clean, very whitish into the bony tunnel. But is it really the best way to prepare our graft? We at the very beginning thought that muscle tissue itself really does possess some sort of stem cell population, some sort of cells that could enhance healing process of the ACL graft when it is preserved on the tendons, and that it helps at these critical points like tendon to bone ingrowth and the ligamentization of the graft within the joint. So this was a study. It was a controlled laboratory study with human samples from gracilis and semitendinosus muscles that were collected during ACL surgeries, and we took 4 different samples, and then we compared the stem cell populations and the cells that could enhance really these 2 processes in terms of tendon to bone integration and the ligamentization. So both stem cells, those derived from tendons and the other ones derived from muscle tissue, were in vitro differentiated into osteogenic lineage, and alkaline phosphatase activity was determined at different time points after osteogenic induction. And we did also different types of tests in order to assess mineralization of the culture. Then we also assessed and collected RNAs from osteoblast cultures, and we did some quantitative PCR tests, Western blots, basically in order to test all different possibilities and capacities of stem cell population. So here you see expanded cells from a picture above showing muscle-derived stem cell population, and the lower picture shows tendon-derived stem cells in the culture at the timeline from time point of surgery up to 14 days after surgery. So these are Western blot analysis of collagen type 1 and osteocalcin expression. And we see that there are really huge differences. We compared all these capacities of muscle as well as tendon-derived stem cells to bone marrow-derived stem cells as a control group. And we have seen that there are really different expression levels when we compared muscle-derived stem cells and tendon-derived stem cells. And for different proteins and collagen type 1 and osteocalcin, there are huge differences, showing that at different time points, different stem cell population jump into the process of osteogenesis. So this is as well alkaline phosphatase activity, where we have shown again that there is different activity level comparing muscle-derived stem cells and tendon-derived stem cells, and the muscle-derived stem cell showed much higher capacity in osteogenic process. So again, different levels of proteins, and again the same pattern. Early markers are much higher or highly expressed with muscle-derived stem cells compared to tendon-derived stem cells. Then the late markers are higher with tendon-derived stem cells compared to muscle-derived stem cells. At the time point when we started these studies, the parasites were also under the spotlight in orthopedic biology, because parasites have capacity to become mesenchymal stem cells, and they secrete molecules, and they have capacity to inhibit apoptosis of the cells, which is an important issue with all these grafts that we use. They inhibit scar formation, which is also another important biological process in order to prevent arthrofibrosis, and they stimulate angiogenesis and vessel stability, which is also very useful for the synovial lining and for the ligamentization process in ACL reconstruction biology. So these characteristics of the parasites were very useful from our perspective, and then we tried to see whether the grafts, and you see here, and whether the muscle tissue derived from the grafts that from the tendons that we have harvested possess these parasites or mesenchymal stem cells. And you see muscle tissue here at the above picture with this brownish immunohistological picture, where you have really abundance of parasites in muscle tissue, as opposed to tendon tissue, where you have really no parasites in the structure of the tendon itself. So again, we compared tendons at the higher row of pictures with immunohistology and then muscle tissue, and you see the green dots presenting parasites. So these cells are really more abundant in the muscle tissue, and especially in the muscle tissue that is really lying adjacent to the tendon tissue. So what is then candy stripe graft? So this is the technique that we have. So we have given the name of candy stripe because it has this appearance of red and white stripes. And how is it done? It's really extremely simple technique where you use the Metzenbaum scissors in order to detach gently muscle tissue, and you try to preserve half of millimeter to 1 millimeter of tissue at the graft. So the graft assembly is also important. If you use the fourfold semi-T graft, then care must be taken to obtain muscle tissue evenly along longitudinal axis when the graft is folded, and muscle tissue has to reach bone socket as well as the intra-articular portion of the graft. So what is then biologic glacial reconstruction and how we see it? We tend to preserve the vascularized synovial fold and the remnant of the ACL tissue, because it's very well vascularized from the blood vessels that come from PCL, and we tend to create soft tissue slot where we put our graft in, and we use the slot looks like this from the accessory anteromedial portal, and we tend to put so-called candy striped graft within the socket where the remnants of the native ACL are preserved. So our colleagues from Brazil have accepted this method, and they have already published several studies with clinical results where they have shown that this candy stripe sort of graft enables better control of the volume evenly along the graft length, and that it has also regenerative potential. And we are also conducting studies in order to obtain mid-term and long-term results with the use of this technique. So how does it look like, and why are we conducting this study? This is a semitendinosus graft without muscle tissue preserved, and what we see is at the tendon to bone interface we see liquid, and we see some bony edema 10 months after ACL reconstruction, and we see collection of liquid within the bony tunnel, and that leads to lower contact surface between tendon and bone, and the bone tends to become more sclerotic, as opposed to the case when you use and when you preserve this muscle tissue, and even if you use some materials like screws that are resorbable, then you tend to see just bony edema at the side of the screw where the screw is being resorbed, as opposed to the side where the graft is being integrated within the bony structure and where you have really good connection of the tissue with the bony socket or bony tunnel. So to conclude, results of our study indicate that muscle tissue is better source of stem cells than tendon tissue, that's for sure. And in order to have even better clinical results, we are conducting tissue, but we know that there is really vast enough capacity of muscle tissue for enhancement of bone tendon integration and ligamentization of the grafts, which are really two critical points of graft biology, and consequently muscle tissue should not be treated as waste after harvesting, and we can really integrate the tissue within our grafts with this really straightforward and easy technique of candy stripe approach. So thank you for your attention.
Thank you very much, Prof. That was really brilliant. Food for thought for everyone. But the real question really remains, do we need to do reconstruction or repair? The same question is here. To tell us about ACL repair, we have our own son of soil from Lahore, Dr. Umar Bhatt. He did his graduation from St. Petersburg, Russia, completed his training and fellowship from UK. He established the first fellowship, sports surgery fellowship program in Pakistan. He's a keen researcher and has published extensively in peer-reviewed journals due to his dynamic personality, I would say, and his innovation in the field of sports surgery. He's been now nominated as the vice chair at CCOT Sports Committee from 2021 to 2023. He's going to tell us all about ACL repair, and at the end of this talk, we will start our debate. I already have a few questions to our panelists, so don't go anywhere. After Dr. Umar's talk, we will start our discussion and Q&A session. Thank you.
Thank you very much, Yasser, for such a lovely introduction. I'm honored. I'll be just sharing my screen. The presentation is recorded, so you guys can hear it very well. So let's hope you guys will enjoy it. And then I will be open for any questions.
Thanks very much, the organizing committee, for giving me this opportunity to present the work on primary ACL repair back to the future.
Can you hear me?
I can hear you, but it seems your
slide is not working.
Yeah, it's not working. It's stuck on the first page.
Let me do it again. Give me a second.
Yeah.
Maybe it's just the glitch with the presentation. Let's start again. Some reason. Yeah, it's just
it was working.
Wait a second. I'll just probably exit this.
It's quite exciting to see from the history that even during the Roman Empire, Greek physicians
is it working now,
used
Yasser?
to show interest
Yeah.
in ACL.
Okay.
You can start sharing.
We know that ACL is a common injury, and over 200,000.
Share your screen, Umar.
Wait a second. I thought I shared already. Wait a second.
No. Yeah.
Okay. I'm so sorry, guys. There we go. Okay, share screen. And let's start from here. Let's hope it works. And let's see now.
We know that ACL is a common injury, and over 200,000 injury happens in USA. Reconstruction is still considered a gold standard. But we also know from the fact that it doesn't come without complication, with risk of infection, revision, dissatisfaction, anterior knee pain, warts atrophy, and osteoarthritis. Today, our debate is why primary ACL repair and reconstruction, which both started together, one took popularity over other. If we look at the history, Mayo Robson performed the first primary ACL repair in 41-year-old minors. During the same time in 1970s, Haygroves published his work on ACL reconstruction. So why this paradigm shift happened? In early 1990s, several randomized controlled trials were performed, showing superior result of reconstruction. Let's look at the evolution of primary ACL repair through the prism of modern day understanding. The turning point happened when Sherman in 1991 understood and re-looked at the result of primary ACL repair. And he divided ACL tear into 4 subgroups. Type 1, which is proximal tear, less than 30% separation. Type 2, more than 30% separation. Type 3, mid-substance. And type 4, from the tibial sided avulsion. And he found that type 1 and type 2 tear have the best result. Through the literature in 1980s to 90, the result showed in mid-substance to be the worst and higher failure rate. But during the same time, other studies by Kune, Janelin, and Ronist showed much better and satisfactory results in proximal tear. Janelin found that in 42 patients proximal tear, at 5 to 7 year follow-up, 86% of patients were satisfied. So what were the factors that played a role in this paradigm shift from a repair toward reconstruction? During the early 80s and 90s, Google and Embase were not as much popularized and easy to use for orthopedic surgeons. The language barrier was another concern. Majority of the literature was written in a foreign language. Authors focused more on developing equipment to support reconstruction rather than repair. It was not popular among surgeons.
There's a background noise, Yasser.
Yes, someone, can you please mute your mic?
Can you please mute your voice, please? There's a lot of noise.
In their study, they took the samples and looked at the histological and cellular evaluation. And they found that
Guys, please stop your mic.
Numerous receptor.
But lecture there.
Guys, you need to stop your voice. Yasser, can you hear this? There is a lot of noise in the background. We need to pause all the participants.
Study in which we took samples along with our histopathologist colleague. 20 damaged samples and 6 normal samples. We use CD34 immunohistochemical staining, which expresses cell surface marker. And we also identified fibroblast. We used hematoxylin and eosin staining. And when we compared the cellular characteristic in total of 52 biopsy samples between a healthy and torn, partial and complete ACL tear, we identified that in a torn ACL, there was a significant higher values in synovial angiogenesis, ligament angiogenesis, and fibrocytes. But the most exciting part of the study was time-specific response, that the remnant angiogenic potential significantly decreased 1 year after the injury. So either you intervene early to preserve the stump or repair. Our study was published in the Knee Journal, and we also presented during the ICRS. So what's happening now that we are back to the future and primary ACL repair is becoming more popular? There are various options to do primary ACL repair: suture anchor repair, bridge enhanced ACL repair, internal bracing, and dynamic intra-ligament stabilization. We do not publishing more and more work on primary ACL repair in the last 2 years. Inspiration is from Phyllis, dear friend who has published the work on primary ACL repair.
Omar, can you pause your screen for a second, please? Hi guys, can everyone please mute your mic? Can everyone please mute your mic? Everyone, please. Hello.
आप लोगों की बैकग्राउंड नॉइज की वजह से बेटा बहुत नॉइज आ रहा है, आप प्लीज अपना माइक को म्यूट कर दें ताकि प्रेजेंटेशन लोग सुन सकें। थैंक यू। आप लोगों की आवाज आ रही है, आप अपनी स्क्रीन पे जाके माइक को म्यूट कर दें प्लीज।
The host can do it, please.
I'm trying to do that.
And I'll try to see if I can mute them.
Yeah, I can make your co-host.
आपको आवाज आ रही है बच्चों, आपको आवाज आ रही है? कैन यू हियर अस? आप बोल दो
माइक कंपनी कहला के वीडियो दा कई दा पूरा दागा चेस्ता सला से खराब हो
هاي هو بختو start شو
हां बोलो।
دا माइक دی बंद कर दे सर लगे हम पख्तो की या सर खबर कोम दा माइकونه خپل बंद के आवाजونه बंद के स्टाफ सला से पूरा कॉन्फ्रेंस खराब है।
Yasir, who are these guys?
I'm trying to see. They're from Peshawar, I suppose, from KPK. Or somebody who's trying to...
आपको आवाज आ रही है हमारी, ये जो बात कर रहे हैं लड़के? आपको हमारी आवाज आ रही है? साथ किधर है? उसको चाहिए कि इसको जरा म्यूट कर दें, जो मेन एडमिनिस्ट्रेटर है। आप जरा माइक बंद कर दें प्लीज अपना, या अपना वॉल्यूम बंद कर दें लैपटॉप का, इसलिए कि आपकी आवाज की वजह से पूरी डिस्टर्ब हो रहा है प्रेजेंटेशन। थैंक यू। ओके, लेट्स स्टार्ट अगेन। Sorry guys.
Screw lock plus an internal brace to repair is primary ACL repair. Bridge enhanced ACL repair was published by Murray and studied, in which you take a sponge of a scaffold attached to the torn end of the ACL, take a patient blood, infiltrate into it, and in the trial, which was done in 2016 of 10 selected patients, in 2019, the published result of 2 years showed similar outcome to ACL reconstruction. Internal brace was developed by Gordon McKay from Scotland, in which the concept of an internal brace is exactly like a seat belt. You repair the ACL, and like a seat belt, it will prevent the graft from rupturing. A 68 patient case series at 1 year follow-up showed 1% failure and 4% revision. Dynamic intraligament stabilization has been studied the most. The largest case series on humans, over 300 patients, has shown much higher failure rate at 5 years follow-up. The intraligament stabilization fixes on the proximal part with endo button and dynamic stabilizer onto the tibial side. But the issue is that you have to remove the screw 6 months following surgery. So the patient potentially needs to undergo 2 surgeries. When I developed my technique of primary ACL repair, my concern were drilling the tunnels, removal of hardware, ease of during surgery, and cost. So I decided to use a single anchor, focus mostly on type 1 and 2 tear, no tunnels, and easy to revise. And that was my approach. So my indication was type 1 and type 2 tear, age over 25, because I feel they do much better Then a younger age, clinical exam plus MRI scan, arthroscopic exam to proceed. Good tissue quality to hold the sutures, and in grade 2-3 cartilage damage and multi-ligament, we excluded our patient. So I will quickly take you through the procedure. How we do our primary ACL repair. MRI scan is showing proximal tear. And as you can see, the rest of the ligament is still attached. With the help of arthroscope, I use 3-portal technique, anteromedial, anterolateral, and the central port. The central port is important not only for visualization, but also for suture management. Examine the ACL tissue. And then basic instrumentation is used: suture cutter, suture passer, drill bit, drill guide, suture manipulator, and suture. I only use 2 suture. With the first suture, which is the locking stitch, you hold the tissue, and the running stitch is the second suture. It's very important to be very careful not to take the suture alongside the PCL. So you have to rotate your arm or use a probe to bring the loop or the Vanel stitch more proximal as possible, close to the footprint. Once all sutures are done, with the help of the drill guide exactly at the position of the footprint, you drill and then use your anchor. I use relax anchor that can accommodate 4 ends of the suture. It's technically easy to use. And once all 4 ends of the sutures are deployed, you insert the anchor into the area of the drill part of the anchor and then tension it so that there isn't any slack. And finally, you can insert the anchor up to the black dotted line. You remove the white end of the sutures and you do the tensioning effect to allow, if there is any minimum slack, to be removed. Once that is done, the anchor is removed. Nice and stable graft. You feed it with the probe, as you can see. It looks nice and stable. Cut the suture end, take the knee through range of movement. Perform microfracture to allow pleuropotential cell to fall onto the graft. And with the 3-portal technique, the ACL primary repair has been done. 24 months follow-up is showing nice position of the anchor with completely healed ACL tissue, and clinical examination is showing stable graft. We have done so far 52 patients, no failure, no revision at almost 2 years follow-up. We are following them with IKTC and Tegner score. MRI scan is done at 6 months, and we will be running our first randomized control trial by end of this year. You can also consider repairing type 4 tear, which I have done in quite a few cases with successful result, but if it is done acutely, these are the patients after primary ACL repair. So in conclusion, the way we preserve the nature, we should save the ACL. Thank you very much.
Yasir, I just whizzed through a couple of the slides quickly because we were running out of time. Sorry, guys, because of this interruption. As you know, nowadays, these computer system does play up a bit. I'm really sorry about that. So I'm open to any questions. And because the presentation was old, almost a few months back, so I accidentally, obviously, did not over-record it on it. So we have done over 80 ACL repairs so far. So the numbers are now more than that.
Yeah, that's excellent. Yes, we are running over time. So let me just take a few questions we have. So I have first question to Prof. Damer. The question is from Dr. Asfar. Does leaving muscle tissue with tendon graft increases infection rate? Prof. Damer.
No, can you hear me?
Yes, we can hear you, Damir.
Okay. So in our patient pool, we started to perform this sort of technique, let's say six years ago, and we didn't observe any higher infection rate. And there is also a biological rationale behind it. And it says that the more living cells you have on a certain graft, the lower the rate, the lower infection rate is. And that's also, if you know it, there is a very well-known work from Cristina. That's an author that was very oftenly cited in terms of implant-related infections, and it says that any surface that you tend to implant, especially within a joint and especially within the knee, is exposed to so-called race for the surface, and this race for the surface is kind of a race between all the extracellular matrix proteins, and in this case synovial fluid, and all the bacteria at the skin. So the less cells you have on any sort of material, being that an implant or a graft, the higher the rate for infection is. And in this case, when you preserve muscle tissue, you have much higher abundance of cells, because even the tenocytes are really scarcely present in the graft if you leave just tendons. So that's the rationale behind the fact that we didn't see any sort of higher infection rate when we preserve tendons, when we preserve muscles, muscle tissue at the graft.
Yasir, your voice is muted. Unmute your voice before talking.
Okay. Sorry. Next question to you again, Prof. I know you answered on the chat box, but this is a question from a very interesting one from Dr. Imran Kesrani. Now, how much muscle to retain with the tendon? And if, for example, too much is preserved, it will necrose, obviously, and cause loosening in the canal, especially tibial side, where I normally use a screw, which will cause it to lose all its tension altogether. So your advice, please.
So I've shown within the presentation that we tend to preserve approximately half of a millimeter up to 1 millimeter of muscle tissue, and that's that corresponds with our histological findings, where we have seen that the abundance of all these mesenchymal stem cells that are very important for biology is especially high at the junction between muscle tissue and the tendon itself. So if this sort of layer, then that's a relatively thin sort of layer, then you have this biological effect that we tend to use in order to enhance biology of the graft.
Thank you. I hope this answers your question, Dr. Kesrani. So there is a question to Dr. Acl. What is your opinion on synthetic versus autograft for ALL reconstruction?
So I have never used synthetic grafts for ALL reconstruction. Probably it's a solution, but it costs a lot. We have performed a study if the hamstrings are always okay to perform an ALL and adequate to perform an ALL, and we found that always the length it was okay. So we didn't have any problem to do it with the hamstring. So what's the reason to use a synthetic? So synthetic sometimes, what I have seen is when I have used a lot of sutures to secure the gracilis, sometimes the suture was causing irritation to the iliotibial band. I don't know if the synthetic comes, probably they can do the same thing, or to produce an irritation or an inflammation there. So I don't know. I do not have experience. Why not sometimes if you don't have any other graft? But if you're normally going to do it, the hamstrings are really, really okay.
Right. Any other panelists have any experience using synthetic graft for ALM?
I mean, I don't have experience of using synthetics. My fellowship in Bournemouth, one of the surgeons over there, Charles Willis Owen, used to use it in selected cases. And certainly, you know, kind of, I suppose your advantages are that it avoids donor site morbidity by harvesting their own graft. And, you know, you're not worried about length. You know, you can adjust it accordingly and fix it in your tunnels in the femur and the tibia. And his technique was very good, very slick and quick, although I failed to find any, you know, kind of studies looking at long-term follow-ups and how they do. And yeah, I mean, he had a very good technique, very, you know, excellent, slick technique. And, you know, he did mention, yes, some people do become uncomfortable. In that case, it's a simple incision and a nick of the tape, which is already tightened and doesn't cause any irritation anymore. So I suppose there's probably a lot to look into this space, because it's an extra-articular synthetic, which probably does better than an intra-articular synthetic.
Right, good, thanks. I hope this answers the question. And the question to all the panelists, and there was once hype for use of peroneus longus muscle for ACL. Any experience and long-term follow-up on its use?
Yeah, so I'll probably answer this question because, you know, Yasser, I started peroneus longus 2.5 years ago, accidentally when I was working in Pakistan, and suddenly during multi-ligament reconstruction, we were struggling with the graft, and one of my friends recommended, let's start peroneus. There is no doubt that it has got a very great potential. We finished our randomized control trial almost now 2.5 years ago, and we're still following them up. They are good grafts. I think they have good value to be used in specific group of patient, but I would still not consider them ideal graft for primary ACL reconstruction. They can be a supplementary graft during bailout methods. So when you're doing your hamstring and you accidentally rupture, or if the thickness of the hamstring is very thin, or when you open up the pes sensorinus and examine the hamstring and you know they're very, very thin and patient is low demand, over 30, non-professional, no ankle instability, no hypermobility, I think peroneus is a very good graft. We have done over 35 patients during our RCT, hopefully soon about to submit it. And we felt that peroneus is a very good graft to be used in a specific group of patients, like in Pakistan, where we don't have availability of allograft, we don't have availability of synthetic graft, especially during revision case, and as a supplementary graft. But we need to wait at least 5 to 7 years before we will come up with this final decision, doing more scientific evidence, biomechanical testing of foot and ankle gait analysis, with more vigorous testing, which we done dynanometer testing, to identify either these patients will have long-term ankle instability or not. But we need to have many tools in the box during surgery. So yes, I feel it's a good graft used.
So would you consider PL graft preferable for sportsmen over BTB or hams or quads?
Is this question to me, Yasser?
Yeah, what you are all the panelists. Would we consider this as a good graft in a sportsman?
I think, Yasser, I would go for a historic evidence-based graft, which we have a track record of many years. I would not consider it as a primary graft in my routine practice. I'm a high volume ACL surgeon, as you know. I don't do, I do big volume of ACLs, and I've been using hamstring for many years, and I would stick to my hamstring until unless I do peroneus longus in a very specific group of patients. Since I stopped my randomized control trial, I only use peroneus during my revision case or during when I'm doing multi-ligament. Otherwise, I'm not using it as a routine graft. Even though they're very good, very easy to harvest. and I haven't found any problem so far with the patient.
So there's another question from Dr. Malik. When will you use all-in primary reconstruction? Am I getting it right? All-in primary reconstruction. Okay.
I think they probably mean all inside.
Yeah.
All inside, maybe. Yeah. Okay. So, Prof. Damer or knife? Anyone?
So at the ROH, we have surgeons who use the all inside technique, and certainly, the technique has, kind of advantages with regards to less morbidity in patients because your incisions are not as long.
Oh, wait, sorry. I think what he means is that when will you use ALL in primary? So when will you incorporate ALL reconstruction with your primary ACL? I think that's the question. So that's to Dr. Acl, I suppose.
To understand it is when I'm performing an ALL with an ACL repair or with an ACL reconstruction.
Yes. What are the indications basically
for the ALL?
For ALL with ACL, yes.
So right now I have increased a lot the ALL. I'm performing more and more the.
Omar, mute your mic, please.
I'm so sorry.
So I'm performing more and more the ALL because I have nothing to lose. I do not have many complications. I do not have more complications by comparing to the normal ACL reconstruction. When I'm deciding to do an ACL repair, I'm always performing an ALL because I think this protects a little bit the ACL repair. But I'm performing in all patients that are a sports guy with a technical activity right now, even more than 4. When they have a laxity above the 5 millimeters compared to the other side, the pivot shift test 2, a small age and second fracture, and it's on almost 90% of my patients right now. It's a little bit that it has a learning curve, a little bit learning curve, but now right now for me it's a little bit, it's about 1 hour. So I have my assistant that he's preparing the graft. I am preparing the tunnels, and we can do it in about 40 minutes. So
yeah, that's brilliant. I totally agree. I think it's all about choosing the right patient for the right surgery. So one more question, and I think that will be the last because I think we are over time now. So last question is: mid-substance tears are excluded of surgery, and is there any difference in post-op rehab in ACL repair or reconstruction?
I think the rehabilitation after ACL repair is much faster because the patient doesn't feel that much pain. You're not taking hamstring, you're not drilling the tunnel, you're not causing them any major damage to the knee. You are sticking the ACL back onto the footprint. So that's the answer to the question regarding rehab. So I found that the rehab is much faster, even though I take them exactly the same way as we do reconstruction. Back to the sports. With regards to mid-substance tear, as I shown in the study in 1970s, the biggest reason of failure were mid-substance. So I would not consider repairing the mid-substance ACL tear. I would only consider doing ACL repair in proximal tear type 1 and type 2, or tibial avulsion, especially in very young patients, not over 25. I would not even repair tibial spine avulsion over 25. They do very bad, no matter what technique you used. In my experience, I've seen bad results. So I just straightforward do reconstruction.
Very much. And I think to this, we will conclude our session, this webinar. I once again thanks all the panelists to take their time out from their busy schedule. I know we are from different time zones and you had to wake up early to be ready for this, and you had to spend some time to prepare the talks. And I would thank all the attendees who, despite being on Sunday, usually in Pakistan, you go out with families and you visit some, and you stayed around and listen to this excellent webinar. Thank you very much, everyone. Hopefully, from the platform of Acl Orthopedics, we will see you again. Thank you, everyone.